Interbody fusion initially was commenced with posterior lumbar interbody fusion in 1950s by Cloward. However, PLIF had a lot of significant morbidity, and hence open TLIF came into being, which was introduced by Harms, and which reduced the complications of PLIF, leading to reduced dural sac retraction, reduced incidence of nerve root injury. However, conventional open TLIF had a significant soft tissue morbidity, and hence Foley introduced MIS TLIF, which was used with the help of retractors, reducing the significant soft tissue morbidity. However, MIS TLIF has a limited working space, and visualization through the tubular retractors becomes difficult, increasing the operative time. And hence now the next advancement is the UB TLIF, which has been introduced recently. So our aim including degenerative listhesis and lytic spondylolisthesis. Infection, trauma, and previous spinal surgery were excluded from our study. Coming to the surgical technique for MIS TLIF, first we do the level marking. The pedicles are marked of the index vertebra in the anteroposterior and the lateral shoot. An incision is taken 3 centimeters from lateral to the midline, going by the Wilsey approach. We incise the skin and subcutaneous tissue, and the muscle fascia is cut. Then we identify the intermuscular plane, and with the finger dissection, we go through the longismus and the multifidus muscle and reach directly at the facet joint. Serial dilators are used over the facet joint, and then self-rating retractors are inserted. This is the O-arm setup which we use in our system. That is the optical camera in the center of the O-arm, and that is the O-arm gantry and the stealth station. The advantage of the 3D shoot is there is no radiation exposure to the surgeon as well as the staff, because the surgeon and the staff are outside the operation theatre during the time of the CT scan. However, the patient is exposed to the O-arm navigation CT scan as the patient is inside. With the help of the once we are at the facet joints and the tubular retractors are in place, the screws are inserted through the navigation system, and we can accurately place the screws. After the screws insertion, we do the decompression. This is the transfascial decompression. We can visualize the decompressed cord and the nerve root as well as the screws inserted through the same incision. The cage placement can accurately be checked through the O-arm regarding the size and the exactness of the placement of the cage. This is the post-operative 3D shoot showing the accurate placement of the screws. If any screws requires revision, or that can be done intraoperatively in the operation theatre. Coming to the UB TLIF, the surgical technique, the skin marking is at the center of the pedicle. In the AP and the lateral shoot, on the 2D in the O-arm, we do that. After the skin markings, the triangulation is done. So a UB TLIF in comparison to MIS TLIF, the difference is we have a working and a viewing portal. Whereas in MIS TLIF, we just go with the help of the serial dilators and the self-ending retractor. So triangulation is done at the spinolaminar junction. The mira is attached at the cranial end. That is for the O-arm reference. The working and the viewing portals are created. The instrument in the viewing portal is navigated. So exactness of the portal can be determined with the help of the O-arm navigation, and where we are exactly can be dynamically located, and exactness can be seen with the help of the navigation system. So targeted approach is very much possible with this technique. Endoscopy being a highly targeted approach, and pathology is very precisely located. This navigation helps us to accurately locate the pathology and place our portals exactly where we require them, and deal with it. So for the UB TLIF, we first do the decompression. Decompression is followed by the cage insertion through the working portal, and after the cage insertion, we put the MIS pedicle screws. So the ipsilateral pedicle screws are put through the same viewing and the working portal. and we take two separate incisions for the opposite side pedicle screws. So as we know, there is no working space, there is no joint space in the lumbar spine. So we have to create space in the lumbar spine. This is done with the help of the RF ablation. We do the laminotomy. This is followed by discectomy and adequate decompression achieved, and then the cage placement. So this is how the final picture looks after the insertion of the screws. This is the end photo. These are the 2D shoots. So coming to the results, the UB TLIF and the MI TLIF, this is the demographic data. Coming to the results, we have a significant difference at the time to ambulation and the duration of the hospital stay. UB TLIF, the average duration of hospital stay was 3 days, and the time to ambulation was 13 hours as compared to MI TLIF, which was 18 hours, and the hospital stay for MI TLIF was 4.8 days. We did not find any significant difference in the fusion rates of the two groups. The VAC score at 2 weeks postoperatively was significantly less for UB TLIF as compared to MI TLIF. However, the VAS at all other times was, VAS and the ODI score was not significantly different. So UB TLIF has a steep learning curve. It has an increased operative time. There is a increased risk of radiation exposure due to the placement of the MI screws and the cage. So the major roadblock is understanding the anatomy through the endoscope and exactness of the procedure. Often the most challenging aspect in endoscopic TLIF is taking the first incision, taking the skin incision, which needs to be precise, and our O-arm helps in doing that. So navigation helps in precise incision and portal placement, prevents inadvertent neurological injury. We can effectively assess the extent of decompression after the decompression with the use of navigation. So the advantages of CT navigation include a reduced learning curve.
Please sum it up, please.
Yes, reduced cannula placement time, reduced total operative time, and reduced radiation exposure to the operative team. This is a paper published by AO et al. Evaluating the CT-based navigation for lumbar endoscopic spine surgery. They concluded that navigation eases the learning curve, decreases cannula placement time, total operative time, and reduced radiation exposure to the surgical staff. So in conclusion, UB TLIF has reduced our hospital stay, has a lesser early post-op back pain at 2 weeks, earlier ambulation. However, fusion rates are similar to MI TLIF. This is a case of UB TLIF, a 50-year-old male.
Please take over the next paper.
Yes.
Next
final photo. Thank you.